Welcome to the deep dive. Today we are undertaking a really deep exploration into one of the most rigorously structured strategic manuals in all of modern cardiology. We're talking about the Heart Failure Playbook.
Yeah, and it's so much more than just a guideline, you know. It really is, as you say, a true playbook.
Mhm.
It's this highly structured, evidence-based strategy that has just fundamentally revolutionized how we manage heart failure.
How so? I mean, what's the big shift?
Well, the focus over the last decade has moved entirely away from just, treating fluid and symptoms. Now it's about enacting a deliberate, sequential, step-by-step strategy aimed directly at reducing long-term mortality.
So our mission today is to really distill this complex framework into its core architecture for you, the listener. Because heart failure management, I mean, with all its acronyms, specific dosing, the really stringent monitoring, it can be overwhelming.
It's a lot.
It is. We want to cut through the noise and show you the strategic design, helping you understand not just what the treatment is, but why it's prioritized in that specific order.
And what's truly critical to appreciate from the very outset is that the entire strategic playbook, it's built on this massive three-part foundation.
Okay.
These three complementary approaches, they have to work together. You have to recognize that heart failure is a chronic, progressive, and importantly, a multi-system disease.
Okay, let's unpack that foundational strategy right away then. What's the first part?
The first part is the clinical framework. You can think of this as the operational side of care, the logistics.
The how-to.
Exactly. It mandates the comprehensive integration of guideline-directed medical therapy, or GDMT, across the patient's entire care plan.
So making sure the right drugs are actually being used.
Yes. And it's also intensely focused on symptom management and quality of life. And crucially, making sure that every provider, from the cardiologist to the primary care doctor to the pharmacist, the nurse, is aligned through multidisciplinary care coordination. It's the logistics of successfully delivering really complex care.
Got it. Okay, so that's the framework. What's part two?
Part two is where we get into the tactical weapons. This is the pharmacologic strategy. This is the engine room of the whole thing.
The drugs themselves.
The drugs. It's focused specifically on the four essential drug classes that we often call the four pillars. So we're talking about RAAS inhibition, that's your angiotensin system blockers, the critical use of specific beta blockers for rate control and reverse remodeling, mineralocorticoid receptor antagonists, or MRAs, and the newest foundational group, SGLT2 inhibitors.
And the third part of that foundation.
The third part wraps it all together. It's the patient-centered approach. This really acknowledges the chronic nature of the disease and the high demands placed on the patient.
Right, because they're the ones living with it day in and day out.
Precisely.
Right.
So this includes essential elements like shared decision-making and education, making sure the patient actually understands why they're taking all these medications. It includes the growing role of remote monitoring and telehealth, and comprehensive lifestyle optimization and self-care support.
So if we connect this back to the bigger picture, it sounds like this comprehensive, three-pronged, holistic approach is what defines modern management.
It is. I mean,
Yeah.
historically, care often focused pretty much solely on diuretics to relieve congestion.
Right, the water pill.
Yeah,
Yeah.
take this Lasix and call me in the morning. Now, congestion management is just one tactic within a much, much larger mortality-focused strategic map.
And that strategic map, you mentioned it's been redrawn recently. There's a specific class of medication that's kind of forced that.
Oh, completely.
So before we dive into the full structure, we need to hit you with the most current, powerful initial takeaway, the foundational shift.
That shift centers entirely on the SGLT2 inhibitors, specifically dapagliflozin and empagliflozin. The evidence now demonstrates a definitive significant reduction in cardiovascular death and heart failure hospitalization. And this is the key part. Across all left ventricular ejection fraction ranges.
Wait, all ranges. Say that again, because that is huge. For decades, pharmacotherapy was strictly divided, right?
Yeah.
You had specific drugs for reduced function, HFrEF, and then almost nothing proven for preserved function, HFpEF.
Exactly.
So the fact that a single drug class is showing this broad effectiveness that just simplifies the entire strategic approach, it acts as a universal foundational pillar.
It's a monumental change. It's a true paradigm shift. It means that regardless of whether the patient have a pumping problem or a relaxation and stiffness problem, the SGLT2 inhibitor is now a fundamental requirement.
And what does that tell us about the disease itself?
Well, it reflects a growing understanding of heart failure, not just as a mechanical failure, a bad pump, but as a systemic metabolic disease. And these drugs, they address that metabolic component beautifully.
That really sets the stage for the depth of change we're looking at. But to even begin applying this complex playbook, we first have to accurately define the patient. We need to figure out exactly what kind of heart failure we're dealing with, right?
Absolutely. You can't run the play if you don't know the game situation.
So, if the pharmacologic strategy is the engine, defining the patient is the navigation system, we need to transition now into the strategic necessity of diagnosis and staging. Before you can choose the right play, you have to know the field and, know your players.
That's a perfect analogy. Heart failure diagnosis and staging isn't a single data point. It requires looking through two distinct but complementary lenses. The first lens tells you how the heart is currently functioning, its pumpability.
Okay.
And the second lens tells you where the disease is in its progression timeline. You need both to make the right call.
Let's start with that first one then. Lens 1, classification by ejection fraction, or LVEF. This is the one most people have probably heard of. It's that functional measure, the percentage of blood the left ventricle pumps out with each beat.
Right. And the most traditional category, and the one where GDMT has historically achieved its biggest mortality reduction, is HFrEF, or heart failure with reduced ejection fraction. This is defined by an LVEF of 40% or less.
So the classic systolic failure, the heart muscle is weak, it can't push blood effectively.
That's the one. Then you have the intermediate zone,
The gray area.
the gray area, which is HFMREF, heart failure with mildly reduced ejection fraction. That's an LVEF between 41 and 49%.
And what's the clinical importance of this category? Is it treated differently?
Well, that's the key. The treatment strategy is robust. It generally mirrors the aggressive GDMT strategies we use for HFrEF. The underlying pathology is similar enough that these patients, they really do reap comparable benefits from the same foundational therapies. So we treat them just as aggressively.
Okay. So on the opposite side of the spectrum, you have the case where the pumping function looks fine on the echocardiogram screen. You have HFpEF, heart failure with preserved ejection fraction. This is an LVEF of 50% or greater.
And this is where the nuance is absolutely essential. It's not just about a preserved number. The definition requires evidence of increased left ventricular, or LV, filling pressures.
So what does that mean in simple terms?
It means the problem here isn't muscle weakness, it's muscle stiffness. It's an inability for the heart to relax and fill properly. So you have a heart that looks normal in terms of its output percentage, but functionally, it's choking on its own pressure, especially when it's stressed. It can't handle the incoming volume.
And finally, there's a category that is really a testament to the success of the very therapies we're about to discuss. HFIMP-EF, heart failure with improved ejection fraction.
This is a fascinating group. This patient previously had an LVEF of 40% or less, but through successful treatment, through the GDMT we're about to detail, their LVEF has improved to greater than 40%.
Now, here is where it gets really, really interesting, because you might logically conclude, great, the treatment worked, the disease is cured, we can stop the meds.
Right, a very dangerous assumption.
And the source material gives a very sharp, very counterintuitive insight here.
This is one of the most vital clinical pearls, and it comes directly from trial data. You must not discontinue guideline-directed medical therapy in these improved patients.
Why not? What happens?
The evidence, specifically from a trial called TREAD-HF, showed that withdrawal of therapy leads to a shockingly high rate of relapse. A significant percentage of patients saw their EF drop right back down and their symptoms returned, often very quickly.
So the patient isn't cured, their disease is simply being suppressed by the therapy.
Exactly. The improvement is proof that the therapy is essential, not that the disease has vanished. We have to stress the importance of continuous lifelong treatment in these patients. The GDMT has become the heart's essential permanent support system. If you take it away, the heart decompensates.
That's a critical point. Okay, so now that we've defined the function with LVEF, let's switch lenses to lens 2. Staging by clinical progression using the ACAH system. This tells us when to intervene.
Right. This staging is a roadmap of the disease, and it runs all the way from just being at risk to having advanced failure. What's important here is that it emphasizes prevention and early aggressive action. It ensures we don't just wait for symptoms to begin treatment.
Okay, so let's walk through them. Stage A is the at-risk category.
Correct. These patients are not sick yet. They have no structural heart disease, but they have major risk factors. Things like uncontrolled hypertension, HTN, or diabetes mellitus, DM.
And the focus here is just
Prevention.
100% preventative. aggressively manage the hypertension, aggressively manage the diabetes to ensure they never progress to actual structural damage.
Then you get to stage B, which is pre-HF.
Right. Now, structural disease is present. Maybe they have left ventricular hypertrophy or LVH from years of high blood pressure, or maybe an echo shows a low but asymptomatic ejection fraction.
But no symptoms yet.
No symptoms. But crucially, we already initiate GDMT at stage B, even though the patient feels perfectly fine.
That seems counterintuitive. Why so early?
Because we are intervening early to try and prevent that inevitable progression to symptomatic failure. We're trying to halt the disease in its tracks before it causes real problems for the patient.
And then we reach the sort of the clinical workhorse of the system, stage C, symptomatic. Yes. Stage C is where most of our focus will be. Here, structural disease is present, and the patient has current or prior symptoms of heart failure, shortness of breath, swelling, fatigue.
So this is where we really ramp things up.
Stage C is the cruising altitude for management. This is the crucial moment where we maximize aggressive therapy. The goal is to initiate the full range of mortality-reducing medications simultaneously to try and induce what we call reverse remodeling, to physically strengthen the heart muscle and stabilize the patient for the long term.
And finally, stage D, advanced.
This is the end stage. It's defined by refractory symptoms, meaning the patient is symptomatic even on optimal GDMT. They require specialized, highly advanced interventions, which we'll discuss later on.
So that dual approach functional classification plus disease staging, it gives the clinician a complete tactical overview. For this next section, it sounds like we're going to focus heavily on the HFrEF phenotype at stage C, because that's where the core GDMT strategy is really maximized for mortality benefit.
Exactly. That's where the playbook is most detailed.
We've established the patient. Now let's move into building the 4 pillars of GDMT. This is section 2, the core formation. And this is the non-negotiable strategy for HFrEF stage C, designed to achieve that reduced mortality and morbidity roof, so to speak.
The tactical directive here is clear and it's aggressive. Initiate all 4 pillars simultaneously or in very rapid sequence. This is a crucial shift from prior strategies where you might start one drug, wait, titrate it up, then start another one.
Right, the old sequential approach.
That's out. We don't want to wait 6 months to fully titrate one drug before starting the next. We introduce them fast because the cumulative synergistic benefit of these 4 drug classes is what induces that long-term reverse remodeling.
Okay, let's start with pillar 1. RAAS inhibition. And within this category, the source material is very clear that the choice is extremely specific.
It is. The gold standard today is the ARNI, which stands for angiotensin receptor neprilysin inhibitor, specifically the drug sacubitril/valsartan. This class received a Class I recommendation, which is the strongest you can get, explicitly stating it is recommended over traditional ACE inhibitors or ARBs to further reduce morbidity and mortality in suitable HFrEF patients.
What was the evidence that forced such a strong recommendation? What made this drug superior?
It was the landmark ADHF trial. That trial compared sacubitril/valsartan against enalapril, which was a gold standard ACE inhibitor at the time. And it found that the ARNI significantly reduced the primary endpoint of cardiovascular death and hospitalization for heart failure.
So it wasn't just as good as the old standard.
It was proven to be superior. It fundamentally changed the guidelines.
Okay, so if the ACE inhibitor already provided that RAS blockade, what's the mechanical advantage of the ARNI? What does the end part do that gives it that superiority?
It's the dual action. The valsartan part provides the standard RAAS blockade by inhibiting the harmful effects of angiotensin II. But the key, the magic, is the sacubitril. It inhibits an enzyme called neprilysin.
And what does neprilysin do?
Neprilysin's job is to degrade beneficial natriuretic peptides, things like BNP and ANP, which the body naturally produces in response to fluid overload and stress on the heart.
So by blocking neprilysin, you're stopping the breakdown of those good peptides. What do those peptides actually do that is so helpful?
They are crucial counter-regulatory hormones. They cause vasodilation. They reduce systemic vascular resistance. They promote natriuresis, which is sodium and water excretion by the kidneys. And importantly, they dampen the sympathetic nervous system and even reduce myocardial fibrosis, which is scarring of the heart muscle.
So you're hitting the problem from 2 sides.
Exactly. By blocking the bad RAS system and simultaneously boosting the good natriuretic system, the ARNI achieves a much more profound, positive neurohormonal blockade. This directly promotes that reverse remodeling we keep talking about.
That makes the superiority crystal clear. Now, let's talk logistics. Dosing. titration. This drug comes with an inherent risk of hypotension, right?
It does. So we must start low. Typically, that's 2426 milligrams or 4951 milligrams twice a day, or BID. But the goal is to aggressively titrate, doubling the dose every 2 to 4 weeks, aiming for the maximum target dose of 9,703 milligrams BID.
And why is hitting that target dose so important?
It's non-negotiable because the mortality benefit that was established in the Paradigm-HF trial was based on reaching that maximal tolerated dosage. That's where the data is.
And you touched on the hypotension risk. That's really the clinical trade-off, isn't it? The higher efficacy often comes with more side effects.
It is the primary trade-off. We have to balance maximizing the life-saving potential of the drug with the patient's comfort and their blood pressure tolerance. If they can't tolerate the target dose because of symptomatic hypotension or dizziness, the clinician has to aim for the highest dose they can tolerate, because any GDMT is better than no GDMT.
And then there's the absolute safety constraint when switching from the older drugs to this new ARNI, the critical washout period.
This is a non-negotiable rule. If a patient is switching from an ACE inhibitor to an ARNI, there is a mandatory 36-hour washout period. That means the patient takes nothing for 36 hours in between.
And the reason for that is?
It's the risk of severe angioedema. ACE inhibitors increase a substance called bradykinin. If sacubitril, the neprilysin blocker, is also active, you get this dangerous buildup of bradykinin, which can lead to life-threatening swelling of the airway. That 36-hour gap ensures the ACE inhibitor is fully cleared from the system.
Okay, so if the ARNI isn't an option for some reason, cost, intolerance, whatever, what are the fallback alternatives?
We default back to a traditional ACE inhibitor, like lisinopril, or an ARB, like valsartan. An ARB is typically preferred if the patient develops that hallmark side effect of an ACE inhibitor, which is that persistent, irritating, dry cough.
Which is another bradykinin side effect.
Exactly.
Okay, that's pillar 1. Moving to pillar 2, beta blockade. The source material emphasized a very specific, very short list of agents. Why is this list so restrictive?
This is another critical point that reflects the precision of GDMT. In chronic HFrEF, only 3 specific agents are proven to reduce mortality and induce reverse remodeling: carvedilol, metoprolol, succinate, the long-acting one, and bisoprolol.
Not just any beta blocker will do.
Absolutely not. The reason for this strict selection lies in the clinical trials and the mechanism. We prioritize beta blockers that lack something called intrinsic sympathomimetic activity, or ISI. That means they don't partially stimulate the receptors they're supposed to be blocking. The 3 proven agents offer pure, beneficial, sympathetic antagonism, which is necessary for the heart to rest and recover.
And the strategy for starting these agents is notoriously cautious, the exact opposite of that aggressive ARNI push.
It is. The strategy is start low, go slow. You must start at a minimal dose and titrate very gradually, usually doubling the dose every 2 weeks or so.
Why so slow?
If you aggressively introduce a beta blocker, you temporarily depress contractility, and you can push an unstable heart straight into acute decompensation or even shock. We have to allow the heart time to adapt to this withdrawal of sympathetic support.
So using carvedilol as an example, you might start at just 3.125 milligrams BID and aim for a high target dose of 25 to 50 milligrams BID. That could take months to get there.
It does, and that duration is a necessary safety feature. We're gradually allowing the heart to undergo that reverse remodeling to reduce its heart rate and to improve function, which is just. It's a slow biological process.
All right, let's cover pillar 3, mineralocorticoid receptor antagonist, MRA therapy.
The 2 main agents here are spironolactone and eplerenone. Their role is powerful. They block aldosterone, which in heart failure causes fluid retention, potassium loss, and critically fibrosis or scarring of the heart muscle. The key indication is for all HFrEF patients with an LVEF of 35% or less and NYHA class 2 to 4 symptoms.
This pillar seems to introduce the highest safety risk profile, primarily around electrolytes. What are the stringent safety constraints clinicians have to adhere to before even starting an MRA?
This is where vigilant monitoring is absolutely paramount. You do not initiate MRA therapy if the patient has hyperkalemia, which is defined as a potassium level greater than 5, or if they have significantly elevated serum creatinine. Usually that cutoff is over 2.5 for men or 2.0 for women.
And that's because of the combined effect with pillar 1?
Precisely. Combining the RAS blockade from pillar 1 with the MRA from pillar 3 creates a very high risk for life-threatening hyperkalemia, especially in patients with poor kidney function.
So if they are eligible and we start, the monitoring protocol has to be incredibly tight to catch those risks early.
It is intensive, especially at the beginning. We check their potassium and their creatinine at 3 days after starting, again at 1 week, again at 1 month, and then we transition to quarterly checks once the patient is stable on a maintenance dose. This protocol prevents catastrophic electrolyte problems.
There's also a crucial practical pearl in the source material regarding the patient's volume status at the time of initiation.
Yes, you must ensure the patient is euvolemic, or dry, before starting MRA therapy. You should never initiate it during an acute decompensation when their volume status is unstable, because that makes their potassium and creatinine levels unreliable and dangerously volatile.
Finally, we reach Pillar 4, SGLT2 inhibitors, which you rightly identified at the top as the paradigm shift.
This is the most exciting advancement in years. Dapagliflozin, or empagliflozin, are now mandated for HFrEF patients because studies like DAPA-HF and EMPEROR-Reduced showed they reduce cardiovascular death and HF hospitalization in this population. And again, this benefit holds true regardless of their diabetic status.
That's the key. The benefit is independent of blood sugar control. So if they aren't really working on blood sugar, how are they providing such massive cardiac protection?
They work through these fascinating multi-system mechanisms. They do cause osmotic diuresis and natriuresis by inhibiting glucose and sodium reabsorption in the kidney, so they provide a mild, kidney-driven diuretic effect that helps with volume management.
But that doesn't sound like enough to explain the mortality benefit.
It's not. The most important part seems to be the direct cardiac metabolic benefits. They appear to force the heart muscle to switch its fuel source from less efficient fatty acids to ketones, which makes the failing heart muscle more efficient and less stressed. They're also highly kidney protective in the long run.
And the dosing is a breath of fresh air compared to the slow titration of the other pillars.
Oh, absolutely. It's simple and effective. 10 milligrams once daily. Limited, if any, titration required. This simplicity makes them ideal for rapid initiation, fitting perfectly with that goal of simultaneous GDMT deployment.
And what about the renal function cutoff for these?
Generally, they're indicated for patients with an estimated glomerular filtration rate, or eGFR, of 20 to 25 or greater. We have to respect those lower limits, but we also recognize the long-term renal protection they offer, which is a massive benefit in a population that's so prone to kidney decline.
So the foundation is set. ARNI, beta blocker, MRA, and SGLT2 inhibitor, all deployed rapidly in HFrEF stage C, each achieving profound neurohormonal or metabolic benefit to reduce mortality and morbidity.
That is the core defense. But heart failure is heterogeneous. Once those four are in place, we then pivot to customizing the strategy for residual problems or unique patient profiles.
That leads us perfectly into the next phase, phenotype-driven therapy intensification. I like the special teams analogy from the outline because it suggests the core formation is strong, and now we bring in targeted specialists to handle unique weaknesses.
That's the concept exactly. Once the foundational four pillars are established, and we've maximized GDMT for the general HFrEF population, we then look at patients who still exhibit specific clinical profiles that require a dedicated, evidence-based intervention. We're tailoring the strategy based on the individual phenotype.
Okay, let's review this intensification matrix, matching the strategy to the patient. We'll start with a population that was specifically identified in the source material, African American patients in NYHA class 3 who were already on optimal GDMT.
Right. This specific demographic has shown a unique and significant benefit when we add an additional class of vasodilation. The intervention is the addition of hydralazine plus isosorbate denitrate.
What's the rationale behind that combination, and why is the demographic distinction so specific?
The evidence comes from the AHF trial. This trial demonstrated that adding this fixed-dose vasodilator combination significantly reduced all-cause mortality and heart failure hospitalization, but specifically in this patient group.
And why is that, do we know?
The thinking is that this combination provides profound arterial and venous vasodilation, and the benefits observed are thought to be related to differences in nitric oxide metabolism and potentially a different responsiveness to standard RAES inhibitors within this population.
Okay, next profile. We look at persistent heart rate issues. So, a patient with a resting heart rate of 70 beats per minute or greater who is in sinus rhythm and is already on the maximum tolerated dose of a beta blocker.
Here, we can't push the beta blocker any higher without risking systemic side effects like fatigue or hypotension. So we need a more targeted form of rate control. The intervention is to add ivabradine.
How does ivabradine work differently from a beta blocker? How does it allow us to hit that specific weight target?
Ivabradine selectively inhibits what's called the funny current, or the phi-phi current in the sinoatrial node. Basically, it slows the heart rate directly at the source without really impacting contractility or blood pressure to the same degree as general sympathetic blockade.
And there's trial data for this.
Yes, the SHIFT trial confirmed that adding ivabradine reduces heart failure hospitalization in patients with an LVEF of 35% or less who meet those specific rate and rhythm criteria. It allows for precision tuning of the heart rate without the side effects of just pushing more and more beta blocker.
Let's discuss a crucial, but I think often missed, systemic issue: iron deficiency.
Iron deficiency is rampant in heart failure patients, even without severe anemia, and it significantly impairs their functional status and their quality of life. The intervention criteria are specific. A ferritin less than 100, or a ferritin between 100 and 300 with a transferrin saturation, or TSAT, of less than 20%.
And the intervention itself is also highly specific, isn't it?
Yes. It requires iron repletion, often using agents like ferrocarboxymaltose. And this is a vital clinical pearl. Oral iron is ineffective in this
It
population.
just doesn't work.
It doesn't. The Iron Out HF trial specifically failed to show any benefit with oral iron, likely due to poor gut absorption and the chronic inflammatory state of heart failure that impairs iron utilization. Therefore, we have to use the intravenous route to reliably improve functional capacity and quality of life.
That's a really practical distinction that can make a huge difference to the patient's daily life, how they feel.
Yeah, absolutely.
Finally, the extremely common comorbidity, atrial fibrillation, AF.
The primary strategy here is centered on safety, and that means stroke prevention. This requires anticoagulation. We generally prefer direct oral anticoagulants, the DOACs, over warfarin. They have fixed dosing and a lower bleeding risk, unless the patient has something like a mechanical heart valve or severe renal impairment.
And what about managing the chaotic rhythm itself in the AF patient who also has HFrEF?
Beta blockers remain the preferred agents for rate control. And that's convenient because we're already using them as a foundational pillar for their mortality benefit. In AF, with heart failure, our goal is typically rate control rather than aggressive rhythm control, unless symptoms are highly refractory. So we prioritize the GDMT beta blockers we discussed in Pillar 2.
So once the 4 pillars are placed, we use these special teams: hydralazine isosorbate dinitrate, ivabradine, Thea iron, and anticoagulation to achieve that optimal personalized stability.
Yes. We transition from these generalized guidelines to highly specific, phenotype-driven therapeutic adjustment. But despite all this optimal chronic care, you have to remember this is a progressive disease, and decompensation is often inevitable.
That's the perfect conceptual bridge. We focused entirely on chronic stable optimization. But the reality of heart failure is that risk of acute crisis. We have to pivot now to managing acute challenges, starting with the immediate problem: fluid overload.
Right. The most frequent reason for hospital admission is acute congestion. This brings us to the congestion playbook, mastering diuretic therapy. The immediate primary goal is rapid symptom relief and returning the patient to a safe euvolemic state, what we call their dry weight.
And the tools for this are the potent loop diuretics: furosemide, bumetanide, and torsemide.
These are the workhorse agents. They act on the loop of Henle in the kidney, where 20 to 25% of filtered sodium is reabsorbed. They can move massive amounts of fluid very quickly, and we have to assess the degree of volume overload to initiate or aggressively titrate the decongestion process. Often this requires IV administration in the acute setting because of better bioavailability.
But the kidney is highly adaptable, and after chronic exposure to these drugs, patients frequently develop diuretic resistance.
It's a massive clinical challenge. Chronic loop diuretic use causes compensatory hypertrophy and structural changes in the distal part of the nephron. The loop of Henle cells adapt, and the distal tubules just get more efficient at absorbing whatever sodium the loop diuretic misses. This creates a ceiling effect where simply escalating the loop diuretic dose doesn't achieve a proportional fluid output.
So you're throwing more drug at the problem, but not getting more of an effect.
Exactly.
So when the standard loop diuretic dose isn't cutting it, we employ 2 specific tactics to overcome this resistance.
Tactic 1 is simply maximizing the delivery of the loop diuretic. We can increase the dosing frequency, so switching from daily to twice daily, or even a continuous 5E infusion in the hospital. The diuretic effect is pretty short-lived, so maintaining a constant concentration helps overcome that resistance.
And tactic 2 is the concept of sequential nephron blockade.
This is the critical synergy. We add a second class of diuretic, specifically a thiazide diuretic like metalazone, about 30 minutes before the loop diuretic dose. The thiazide acts at the distal convoluted tubule, a completely different site of action. So by simultaneously blocking the loop of Henle and the distal tubule, we just overwhelm the nephron's capacity to reabsorb sodium and water. It's a 1-2 punch.
Why specifically metolazone over standard thiazides like hydrochlorothiazide in this acute setting?
That's a great question. Metolazone is chosen because it retains its efficacy even in the setting of reduced renal function, which is so often the case in acute decompensated heart failure. Other thiazides tend to lose their efficacy pretty rapidly when kidney function declines.
That provides a clear, structured way to handle congestion. Now let's move to the most urgent management scenario, the 2-minute drill for acute decompensated heart failure, ADHF.
Managing ADHF requires rapid, accurate hemodynamic categorization because the treatment for one profile can be lethal for another. We assess 2 vital parameters that define the patient's immediate status.
The 2 axes, congestion and perfusion.
Right. Axis 1, congestion. Is the patient wet congested, high central pressures, fluid in the lungs, or are they dry, meaning euvolemic? Axis 2, perfusion. Is the patient warm, well-perfused, adequate output, or are they cold, meaning hypoperfused, poor cardiac output, often manifesting as low blood pressure, cool extremities, or even altered mental status?
And this gives us the ADHF hemodynamic matrix, 4 distinct quadrants, each with its own therapeutic strategy. Let's map them out.
The ideal quadrant, where we want our outpatients to be, is warm and dry, compensated. They are stable, well-perfused, and euvolemic. The strategy here: optimize their oral GDMT and maintain their current diuretic dosing. No immediate crisis.
Okay. Next, the most common hospital admission profile, warm and wet, congested. Perfusion is acceptable, but the patient is overloaded with fluid.
This requires aggressive decongestion. We initiate high-dose IV loop diuretics, starting at a dose often at least 2.5 times the patient's home oral dose.
Why so much higher?
The rationale is that the IV route bypasses inconsistent gut absorption in a congested patient and ensures drug delivery. Now, if their systolic blood pressure is high enough, generally over 110, we can also add IV vasodilators like nitroglycerin. Vasodilators rapidly reduce the filling pressures in the heart, offering very rapid symptom relief by redistributing volume away from the lungs.
Okay, now we enter the hypoperfusion space. This is more dangerous. Let's start with cold and dry, hypoperfused.
This patient is in low output failure but without volume overload. The strategy here is cautious. We might try gentle 5E fluid or resuscitation first, just a small bolus, in case the low perfusion is partly due to overdiuresis or true hypovolemia. If they remain hypoperfused despite fluids, then they require temporary inotropes to boost the heart's contractility.
And the most critical scenario, cold and wet, cardiogenic shock, which carries the worst prognosis.
This is a life-threatening crisis. It requires the most complex, strict sequencing of therapy. The heart cannot push blood, and the body is overloaded. The sequence is vital. First, we administer inotropes to restore cardiac output and perfusion.
Perfusion first.
Always. We cannot start diuresis until the kidneys are being adequately perfused. Once perfusion is restored, then we can cautiously administer diuretics to remove the dangerous congestion. Finally, if shock persists, despite perfusion improvement, we may need vasopressors to maintain blood pressure, but we use these sparingly as they increase afterload, which puts more strain on the failing heart.
You stressed that sequencing. You noted the danger of diuresing a cold patient. Can you elaborate on the rationale there? Why is that so dangerous?
If you try to diurese a cold patient before you restore perfusion, their kidneys are already starved for blood. By removing fluid, you further drop their already low blood pressure, and you can potentially drive them into acute renal failure or just worsen their shock. You have to restore the pump function first, get blood to the kidneys.
Since inotropes are so crucial for that cold patient, let's detail the selection process between the 2 primary agents used.
Right. We have to choose based on the clinical context.
Let's start with dobutamine.
Dobutamine is a beta agonist. It directly stimulates the beta receptors in the heart to increase contractility. It's often preferred if the patient is hypotensive or if they have underlying renal failure because it causes less peripheral vasodilation compared to the alternative.
And that alternative is milrinone.
Milrinone is a phosphodiesterase 3 or PDE3 inhibitor. It's often the preferred choice if the patient is already on chronic beta blocker therapy because it acts via a different pathway. It bypasses the beta receptors that are already blocked by their chronic medications.
But there are cautions.
Major cautions. Milrinone causes significant peripheral vasodilation, which can worsen hypotension, and it is renally cleared, so it requires heavy dose adjustment in patients with kidney impairment.
And in all of this acute chaos, there is one absolute critical safety precaution related to their chronic medications.
This is the golden rule for destabilization. In any destabilized cold patient, you must immediately withhold their beta blocker therapy. A beta blocker actively suppresses heart function, which is the last thing you want when the patient is hypoperfused or in cardiogenic shock.
And when do you restart it?
You reinitiate the beta blocker only once the patient is euvolemic, hemodynamically stable, and successfully weaned off of any inotropes.
That's the full 2-minute drill: rapid assessment, clear categorization, and strict rules that govern both acute and chronic drug management. We've spent a lot of time detailing the HFrEF strategies. Now, let's pivot to the evolving landscape of HFpEF and long-term vigilance. We're focusing on the patient with preserved ejection fraction and LVEF of 50% or greater.
The approach to HFpEF has matured significantly. I mean, historically, we had almost nothing specific for this population besides diuretics. Now, thanks to recent trials, we have definitive strategies that are established.
What are the 3 key therapeutic strategies we apply to the HFpEF patient today?
Strategy 1 is symptom relief. Class 1. Diuretics are absolutely essential for managing the congestion. Because the ventricle is so stiff, even small changes in volume can cause massive spikes in filling pressure, which leads to severe shortness of breath.
Okay. Strategy 2 focuses on hospitalization reduction, class 3. And this is where the newest evidence comes in, and it's a very familiar class of drug.
This is the cornerstone now. The SGLT2 inhibitors, empagliflozin and dapagliflozin, are indicated here. The emperor-preserved and delivered trials conclusively demonstrated that these agents reduce heart failure hospitalizations and cardiovascular death, even in patients with preserved function.
So this validated that idea you mentioned earlier, that HFpEF isn't just a structural problem.
Exactly. It's also a systemic metabolic issue that SGLT2 inhibitors address.
And the third strategy involves MRA therapy, but it's applied more selectively than in HFrEF.
Right. We consider spironolactone. Based on some retrospective analyses of the top PIFICAT trial, spironolactone may reduce hospitalizations, particularly in HFpEF patients who show markers of higher filling pressures, like elevated natriuretic peptides, and who can tolerate the medication without developing hyperkalemia. It's a more nuanced decision.
And underlying all 3 of those strategies is the fundamental historical principle of HFpEF management.
The underlying principle is the aggressive management of comorbidities. HFpEF is often a disease driven by decades of systemic stress, particularly uncontrolled hypertension and atrial fibrillation. If you don't aggressively control the high pressure that caused the heart to stiffen in the first place, no drug is going to fully succeed. Management of HTN and HFpEF is absolutely critical.
That's the evolving treatment side. Let's talk about the long game: monitoring, optimization, and safety. Once the patient is on all these powerful foundational therapies, what are the critical areas of long-term vigilance that define successful chronic care?
The first, which we've mentioned a few times, is the imperative to titrate to target. Clinicians have to aim for the maximal tolerated doses that were used in the trials. Sacubitril/valsartan 9703 BID, metoprolols succinate 200 milligrams daily, because the mortality benefit is dose-dependent. Stopping at subtherapeutic doses means you're leaving that life-extending benefit on the table.
Next is vigilant monitoring for the 2 most common critical issues that come with using the 4 pillars.
We have to anticipate and manage hyperkalemia. It's a frequent issue when you combine RAS inhibitors with MRAs. But instead of just stopping the life-saving GDMT, modern management involves implementing dietary changes and frequently utilizing newer potassium binders, like patiromer. These binders excrete potassium through the gut, which allows the patient to continue receiving the full benefit of their GDMT regimen.
So we treat the side effect to enable the primary therapy.
Exactly.
And the second monitoring issue revolves around expected changes in renal function.
We have to educate both the patient and the care team that a small transient rise in serum creatinine is often expected when you start an SGLT2 inhibitor or during an effective diuresis. The kidney is just showing that it's working harder, or that the filtration pressure has changed slightly. The critical message is, do not prematurely stop GDMT for minor anticipated changes in creatinine. We evaluate, we manage, and we preserve the optimal drug regimen.
Finally, just as crucial as knowing what to start is knowing what to stop. The list of medications that actively harm the HFrEF patient is vital for long-term safety.
This is the de-escalate harmful medications rule.
Ah.
There are 3 main classes that absolutely must be avoided in HFrEF because they worsen function or cause dangerous fluid retention. First, NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen. They can cause fluid retention and increase blood pressure, directly counteracting the effects of our diuretics and REAS inhibitors.
Okay, what's the second class?
Second, non-dihydropyridine calcium channel blockers, or CCBs, drugs like diltiazem or verapamil. These have negative inotropic effects, meaning they depress contractility in an already reduced EF heart, making the failure worse.
And the third group to avoid?
Thiazolidinediones, or TZDs. This is a class of diabetes medication like rosiglitazone. They are notorious for causing significant fluid retention, directly defeating the purpose of our entire decongestion strategy. If a patient with HFrEF is diagnosed with diabetes, these must be avoided. The SGLT2 inhibitor is the preferred agent, as it's now GDMT for both conditions anyway.
Knowing those three classes to avoid is absolutely essential for maintaining stability and maximizing safety during the long game. We have covered the entire spectrum from preventive staging to chronic optimization and acute rescue. Now we arrive at the very end of the line, advanced plays for refractory heart failure, stage D.
Stage D represents just the heartbreaking failure of the heart to respond adequately to optimal GDMT. These patients show classic I need help markers. Refractory symptoms at rest, recurrent, debilitating hospitalizations, or systemic intolerance to the full GDMT regimen. At this point, the focus shifts to highly specialized invasive interventions.
Once that definitive stage D designation is given, the care team outlines 3 strategic paths for the patient.
Path 1 is palliative inotropes. If the patient is not a candidate for, or if they decline, more invasive measures, we may provide a continuous home infusion of milrinone or dobutamine. This is administered purely for symptom relief and to improve quality of life during end-stage disease, understanding that it does not prolong life and is not curative.
A comfort-focused measure.
Exactly. Path 2 is mechanical circulatory support, MCS.
And what does that entail?
This is a major step. It primarily involves implanting a left ventricular assist device, or LVAD. This is a mechanical pump that takes over the function of the failing left ventricle.
And this can be used in 2 ways, right?
Yes. The LVD can be used as a bridge to transplant-sustaining life until a donor heart becomes available, or as destination therapy, meaning it's intended as the permanent solution for patients who are too sick or otherwise ineligible for a transplantation.
And finally, the ultimate path to long-term restoration.
Path 3 is heart transplantation. This remains the gold standard for eligible candidates who are refractory to all other medical and device therapies. It offers the best chance at long-term survival and quality of life, but it requires the patient to meet very stringent health and psychological criteria for eligibility and, of course, the availability of a suitable donor organ.
This entire framework, from stage A prevention all the way through the 4 pillars to the advanced stage D plays, it just gives us such a comprehensive, structured view of the disease and the corresponding therapeutic escalation required at each step. So what does this all mean for you? We set out on this deep dive looking for a detailed playbook, and what we found was this incredibly sophisticated architectural blueprint for chronic disease management.
We saw how diagnosis requires those 2 lenses, functional LVEF and progression staging, to precisely define the patient. We then built the strategic foundation of the 4 pillars RNI, beta blockade, MRA, and SGLT2 inhibitors, which must be initiated rapidly in HFrEF stage C to induce that beneficial reverse remodeling and dramatically reduce mortality.
We then layered on the necessary personalization using special teams like hydralazine isosorbide dinitrate for specific patient profiles or IV iron for functional deficits. And we established the rules for rapid response using that stringent wet-dry, warm-cold matrix to navigate the inherent chaos of acute decompensation and cardiogenic shock.
And we understood the life and death importance of sequencing in that environment.
Right.
The entire system is really defined by this necessary ongoing tension.
Right.
On one hand, you have the aggressive imperative to push GDMT to target doses to maximize long-term survival. On the other, you have the stringent requirement for safety monitoring, constantly checking potassium and serum creatinine to ensure we maintain stability while deploying these powerful, complex agents.
It's a precision science.
It is. It's built on clinical trial evidence. It demands precision, adherence to specific data, and constant learning about what works and what to avoid. It's a field that is always evolving.
Absolutely. And as we finish this deep dive, let's leave you with a provocative thought about the future implications derived from this highly structured framework, especially concerning our initial finding.
Let's reflect once more on those SGLT2 inhibitors. They were designed for the kidney and for diabetes, yet they now hold this crucial position as a foundational pillar across the entire spectrum of heart failure management.
A drug for one disease becomes a cornerstone for another.
Think about the implications of that for medicine overall. a drug class entirely focused on correcting a pathology in one organ system, the kidneys, demonstrated profound systemic cardiovascular and metabolic protection. It really underscores the powerful idea that major breakthroughs often come when we stop viewing the heart, the kidneys, and the endocrine system as isolated domains.
They're all connected.
The successful implementation of this strategic playbook demands that we acknowledge that they are, in fact, one integrated, interconnected system.
It's a profound reminder that the deepest understanding comes from looking across those system boundaries. Take the structured, multi-system thinking and apply it to whatever complex field you are currently exploring. Thanks for joining us for this deep dive.